Hi, I'm Karen Lewis with Willamette Valley Hospice and Palliative Care. You're watching Hospice 101, teaming up with communities and hospices together to give residents the best kind of care. Let's get started. This should be a very short 15-minute video to just tell you how we best work together as a team. And so I'm going to go over some slides. And then if you have any questions, you can always connect with us by calling Willamette Valley Hospice. So quickly, we have a history of hospice in our country. The modern movement was started by Dr. Cicely Saunders in England in 1967. She founded St. Christopher's Hospice in London. In the States, it was Florence Wald who started her own inpatient hospice called Connecticut Hospice in 1971. Both women were friends and learned from each other while they were starting their own hospices. And both Connecticut Hospice and St. Christopher's Hospice are active inpatient hospices still operating today. Fast forward a few years to 1978 and the Willamette Valley, and we established our own community-owned, not-for-profit hospice called Willamette Valley Hospice here in the Willamette Valley by a group of volunteers. WVH is an in-home hospice, which is different than an inpatient hospice. It means that we come to the patient's home, unlike Connecticut Hospice or St. Christopher's. Our teams travel to where the patient is and provide services wherever the patient calls home. We've been serving adults and children in Marion, Polk, and Yamhill counties for over 40 years. And over that time, we've served we've served nearly 30,000 patients and their respective families. Now, I hear from people all the time, what is hospice? It's a philosophy of care. Some people think that it is that we come in at the very end when a person is ready to die, and there is some of that, yes, but truly we try to come in at least 6 months before a person is ready to pass. Because people get the most out of hospice if they have a little bit of time to interact with the nurses and the staff and to get the medications. It's a philosophy of care where we think, all our lives we're on a fix-it plan, and then we kind of move to a comfort plan when we have exhausted all those curative treatments, all that aggressive treatment, and we really recognize that we don't know how much time we have left, but whatever's left, we want to make sure that we don't have to keep fighting and that we can enjoy it as much as possible. So hospice comes in. We do not prolong life and we don't hasten it. We just provide medications and therapies to mitigate any kind of pain or symptom management and to address quality of life issues and make it as wonderful a time as possible for someone before they transition and pass on. So how does one get hospice? Medicare requires 2 physicians to certify a terminal diagnosis that's 6 months or less if the disease were to follow its normal course. This determination is based on chart notes and the disease progression. Now, we can receive a phone call from anyone for services, but ultimately the attending physician, or you sometimes hear it called the PCP, or the hospitalist, needs to refer so we can move forward. It then becomes a collaboration between our medical director and the patient's PCP to confirm eligibility of hospice services. In addition to that, the patient and the family also have to come on board and understand that they're going to choose comfort measures instead of curative measures in order to come onto hospice. So we provide all sorts of things, medications related to the terminal diagnosis, all medical equipment that you might hear referred to as durable medical equipment or DME, all supplies like chucks, depends, catheter supplies, wound supplies, toothettes for mouth care, that kind of thing, and all professional visits from the WVH or the hospice team. And that team is made up of 10 plus team members. The RNCM, the resident registered nurse case manager for the hospice, serves as the coordinator of the care with oversight from the medical director. And he is the one that will mostly interact with the patient and family and your community, whether it be your administrator, your DNS, your RCM, or the caregivers themselves. We have 24-hour 7-day-a-week access. That's not at the bedside necessarily, but we are available by phone. So we'll come in for visits throughout the week. Multiple disciplines will come in. But if you find that your resident is having a problem, call us. Evenings, weekends, holidays, we have a triage nurse that is on staff ready to take your call and can help you triage through whatever problem your resident is having. And then we also have a skeleton crew that can come out and actually provide a visit to your resident in the middle of the night. If it's 3 o'clock in the morning, call us. And then how do we communicate? We communicate 3 different ways. A team to team, so RN communicates with your RN if you have one, or your administrator or med tech, caregivers. You'll see her or him much more often than you will other disciplines. If there's a problem and we need to solve it, we refer to the plan of care quite often. We'll do documentation that will go in the patient's chart, and we'll communicate with each other that way. And then also we can provide education, free education to the community where the residents are. And that can be in the form of Hospice 101 like this presentation, or medication management, body mechanics, grief and loss, avoiding caregiver burnout, all of those things we can provide education around free of charge to the community in the form of an in-service or a video. So I get some common questions when I'm talking to patients and families. Who pays for hospice? How often do you visit? And how do you collaborate with community staff? Well, so every American 65 or older has the hospice benefit built into their Medicare plan. And if you're under 65, most commercial insurances have that benefit in their plan. But regardless of that, we're a not-for-profit hospice that's committed to helping people regardless of your ability to pay. So we also provide that service anywhere the patient calls home. Now, we visit on a regular basis, but the frequency is often determined at the beginning, at the time of admit, or shortly thereafter, when the RN and the patient family and the facility care team sit down to develop the plan of care. And over time, it gets adjusted in concert with your facility team, the family, and the needs of the patient. And we collaborate with the community staff all the time. Each member of our team is assigned to your community. And so you'll know us when we come to visit. You'll see the same faces over and over again, and we find it helps provide consistent, comprehensive care. So pull us aside. We're happy to talk to you and answer any questions you have if you don't understand something that's going on. We want this to be a successful experience for you. So our role, we have roles and you have roles, and then we do some things together. So I'll cover that. We really are there to help the patient find peace and create a positive end-of-life experience by helping to support their culture and spiritual needs and help resolve any kind of conflicts with their families, interpersonal or internal conflicts, maybe their spiritual conflicts. We will help with that. What we expect from you as a community is to assess the comfort in your resident and or the changing condition. Always use the medications as prescribed by the doctor or instructed by the hospice nurse. And when in doubt, always call us first. We're happy to go over that. In fact, Medicare regulations state that when a resident moves into hospice care, the hospice agency is medically responsible to oversee the plan of care. So we're responsible. The buck stops with us. So that's why we want you to feel comfortable talking to us, even though it is your turf. The resident lives in your community. We're really doing this together, and so we want to have that collaborative feel with you. So in that spirit, we want to agree that the patient needs to receive hospice care. We will document communication between each other, and the hospice will order the meds, they'll prescribe the meds, and the community will administer them. And the hospice RN will monitor the ICF care and will train the facility caregivers to achieve patients' maximum comfort and pain relief. So it's really a collaborative effort. We will both communicate bereavement services to the family, and we ask that you and your team direct the patient's family to our hospice, because we can help provide resources for coping grief and loss. We have a very robust bereavement department that can help with that. So you may have some hospice patients that, or some people who you think might be appropriate hospice patients. How do you know? Well, if they have had decreased appetite within 2 to 3 months, frequent hospital visits or trips to the ER, that also is a red flag, or recurrent infections that don't get better despite really aggressive treatment. Also, decrease in their ADLs or uncontrolled pain, nausea, vomiting, any of those things can be a red flag and a potential for a person getting ready to go on to hospice. Let's talk about pain briefly. There are 4: physical, emotional, psychological, and spiritual pain. We see emotional and psychological pain, especially in veterans who've had interactive combat. In identifying pain, if your patient is able, they will tell you that they're experiencing pain. But if not, then you may see that they have some grimacing, moaning, crying out. They may be guarding their body, or they may have rapid or shallow breathing. Call us immediately and let us know so we can intervene and start giving more, start rearranging or figuring out what kind of pain they're having so that we can start addressing it. It doesn't have to be pharmaceutical. Sometimes it can be emotional pain or spiritual pain. Well, we have disciplines that can address that. We have spiritual counselors and MSWs that can come in and address those issues. How do you know if pain is not controlled well? Well, if a patient is complaining of more pain, that's an indication it's not being controlled. But if they're not sleeping, they're agitated, they've had a change in appetite, if they're not able to articulate that to you, but you're seeing these other symptoms, that can also be a red flag. So let's talk about symptoms of dying. We all die of different things, but the way we die is often quite similar. So you're going to see increased sleeping, decreased food intake, because when someone is their body is shutting down, it actually is creating, it's a lot of energy to digest that food. A lot of bodily functions are working, and it takes a lot of energy out of the person. So you may see that eating can become a burden for that person. Don't push it with them. Just understand that this is their body's natural way of declining. You're going to see changes in breathing. Maybe they can't clear fluids. This is a normal part of dying. And if the patient is not choking, but they're able to breathe, you're just hearing that it's kind of a wet, almost a rattle. It may be that the patient is not in distress, but the family may not understand what's happening. If that's what's going on and you're getting questions about that, call us and we can actually come alongside the family and have some conversation with them about what they're seeing. We can educate them as to what the natural progression of someone passing really looks like, and we can take that burden off of you. So once the patient dies, stay calm. Don't call the EMS. In fact, in any situation, once the person comes onto hospice, we are your 911. So you want to call us first. But call us and immediately tell us that what time of death, what time the patient died, and then ask the RN to come out and visit. She could do a family support, but she can also help provide some cleanup for the body as you get it ready for the mortuary. You and the hospice at that point need to decide who will call any extended family and let them know that the patient has passed, and then follow through on that immediately so that that doesn't get forgotten. We will notify the attending physician, county medical examiner, and we'll schedule to have the equipment picked up the next day. Give the family plenty of time to say goodbye. That's really something we want to keep in mind. And understand too that the family's perception, it's the family's perception as to whether or not the death is good or peaceful. And not all deaths are good. Sometimes the hospice and the community can do everything right, and the resident can have a difficult time dying, or the family member may be struggling with the passing of their loved one. If this happens, don't assume that you've done anything wrong. This is the most difficult time in the life of a family. Just simply be supportive and sympathetic as you can. Let's talk about medication destruction. You want to destroy all medications according to the hospice medication destruction policy. If you don't know what that is or you can't lay your hands on it, again, call us and we will walk you through that process. Do not flush the medications down the toilet. That's a big no-no. And if any medications get delivered after death, all you need to do is simply refuse them. So no presentation would be complete during this time of COVID-19 without an infection control piece. So your hand washing protocol is the most important way to prevent the spread of infection. So before touching a patient, providing a clean procedure, or after touching a patient, direct contact with the body fluid, or touching any surfaces around the patient, wash your hands. Same thing with environmental cleaning. Germs and viruses can live in the patient care area for quite a while, and unclean surfaces is the leading cause to infections in healthcare personnel. So watch that. We want to keep you healthy. And standard precautions is the first line of defense when you're breaking the chain of infection, and it assumes that any patient's blood or body fluids can be infectious. So that's why PPE should be worn based on the level of anticipated contact with the patient and the potential exposure for infectious material. So gloves, gowns, face mask, eye protection, all of those should be worn when anticipating potential splashes or sprays of blood or body substances that may occur during the patient care. If you have questions about hospice care or infection control, call us or pull one of our team members aside when you see them in the building. We'll be happy to answer any of your questions. The caregiver shortage in this time is very high. So I want to make sure to thank you for choosing to work in this field and provide the care that you do for your residents. Your care makes a huge impact on the residents' quality of life, and it's paramount for them to live out their days in comfort. So thank you for letting us come alongside you and be a part of your team as we care for your residents together. Thank you so much.